Hi everyone, Dr. Saurabh here. So let us see the quiz on diabetic retinopathy. Now this topic is a very important topic of PG exam. One question most of the most of the times in any exam about this topic. So I am ready to give the test. Let's see the 10 questions. The first question is regarding the true statement of the following. Now, the first statement itself is a false statement because diabetes in the eyes affect micro vessels, not macro vessels. And type 1, almost all the patients develop retinopathy about 15 years. In type 2, risk of increases as the duration of diabetes. Now, second statement is correct, but I don't know about the first statement if 15 years is correct or not. Let us leave this for a while. But the third statement, the most important factor for diabetic retinopathy is not glycemic level, is the duration of diabetes. You should know that. So A option and C option are easy options. Now let us see the D option. The risk of retinopathy at the time of diagnosis is more in type 1. This is false statement. Now life as the duration is a risk factor. So lifelong risk is more in type 1 as compared to type 2. But at the time of diagnosis, the duration is immaterial, irrelevant. So at the time of diagnosis, you will see the age because micro vessels are more affected in old age. So at the time of diagnosis, the risk is more in type 2 as compared to type 1. So D is also wrong. So even if I don't know about the years in B option, that should be true statement because the other ones I should know that they are false statement. So the answer is B. Second question is regarding histology. So there is pericytes, which are cells surrounding the capillaries. They are lost in diabetic retinopathy. I also don't know about thickening of the basement membrane. Maybe you also don't know. But in as the diabetic retinopathy progresses, the capillary occlude. If capillary occlude, retina does not get blood supply. Retina ischemia releases VEGF and causes new vessels inside and outside the vessel. So B option I don't know, but A and C I know that. But D option is reversal of 2 is to 3 is a normal arteriovenous ratio. In diabetes, there is nothing relation of 3 is to 2. That is wrong. There is no reversal of it. In hypertension, there will be 1 is to 3 and complication 1 is to 4 because of tortuous dilated veins. But this arteriovenous ratio is not affected in diabetes, so I should know that. So which of the following is false? D is answer. Even if you don't know A, B, C, D, you should know. The earliest feature of diabetic retinopathy because of loss of pericytes, the capillary microvessels proliferate, and that proliferation is known as microaneurysm. Should be easy question. Seen in nerve fiber layer of the retina. That is a factual thing. And nerve fiber layer or ganglionic cells because the axons of ganglionic cells are nerve fiber layer. Theoretically, microisms are seen in NFL and ganglionic layer. Now, one student asked, what is diabetic maculopathy? What is diabetic retinopathy? Diabetic retinopathy means any changes of diabetes in the retina, but maculopathy means the central part of retina is affected, that is, macula is affected. That can be macular ischemia or it can be macular edema. And maculopathy is the most common cause of decreased vision in diabetes. Is true. Gradual, painless decreased vision in macular edema. And macular edema can be seen in any stage of EDDRS staging. Any stage of EDDRS means NPDR, very mild, mild to moderate, severe, and proliferative. And it is due to leakage of the fluids because of inner blood retinal barrier, means the capillaries of the retina are having disturbance by which the fluids and exudates come out. But it is not managed by pan retinal photocoagulation. It is managed by nowadays anti-VEGF injections because VEGF is a chemical mediator which causes inner blood retinal barrier break. So pan-retinal photocoagulation is a treatment for proliferative stage of diabetic retinopathy when there are new vessels on the disc elsewhere. So this is the left retina fundus picture showing some yellow in clusters, small shiny ones. Now cotton wool spots are soft exudates, they are large and fluffy. Drusens are only in the central retina in an old patient. This is 50-year-old diabetic patient and hemorrhages are red. So it has to be hard exudates. That is lipoproteins coming out of the inner blood vessel barrier, mostly into outer plexiform layer, sometimes radially, sometimes circinate pattern, like circinate means circular pattern like shown over here. Which of the following feature of diabetic retinopathy is seen as hyperfluorescence? Hyper means you are seeing the dye. Only two signs if you attend the class are hyperfluorescence. One is microaneurysms, that is hyperfluorescence dot, and that was an INICT question, and hyperfluorescence branching pattern, that is new vessels, can be disc, can be elsewhere. All rest signs at your level are hypofluorescence, but this answer should be new vessels elsewhere because microisms are hyperfluorescence dots. Now, this procedure is pan retinal photocoagulation, sparing the central retina. You have to destroy the hypoxic retina, convert to anoxic because hypoxic retina liberates VEGF. A option is correct, B option is correct, C option is also correct. And side effect is not centrocecal, side effect is tunnel vision. Central vision is spared, ring scotoma is there. So even if you don't know ABC, you should know by looking at the picture. You are destroying the peripheral retina, sparing the macula, that is tunnel vision, ring scotoma. The only reason for sudden decreased vision and a sudden is vitreous hemorrhage. Macular edema causes gradual, painless decreased vision. Many students must have marked C option. Retinal detachment rhegmatogenous is sudden, but tractional takes time because of new vessels. They pull the retina slowly. That is gradual. And macular ischemia also doesn't cause sudden. Now, diabetic patient complaining of floaters. Now, floaters, if there means vitreous is involved. Seen in the clinic, following findings were there. Visual acuity is less. Anterior segment was having cataract. Posterior segment was clearly visible because something was there in the vitreous. That's why ultrasound B scan was done and low amplitude spikes was seen. So many hints are there that something is in the vitreous. Something in the vitreous means vitreous hemorrhage. And vitreous hemorrhage comes in proliferative stage of diabetic retinopathy. New vessels leak the blood, they come into the vitreous. Doctor cannot see the retina, he will do ultrasound B scan. That is PDR stage. And the poorest prognosis is macular ischemia. If there is ischemia of the macula, you have to laser it because of you have to destroy the hypoxic retina. If you destroy the central retina, the vision will decrease. That's why there is very poor prognosis and generally no treatment done for macular ischemia. So that's the 10 questions. I hope you have done 7 plus correct. Best wishes. See where have you done wrong. Thanks for listening.